Good morning, everyone. We're ready to get started because we have a really great session. So I'm Tim Henry from Christ Hospital in Cincinnati, and I'm one of the moderators. And I'm going to, in a minute, introduce Navin Kapur from Boston, who's not only a moderator, but he's going to introduce one of our talks. All right, with that, Navin is up first, and Navin's going to talk about the year in review for cardiogenic shock, which he wrote almost every one of these papers, most likely.
All right, terrific. Thanks so much, Tim, and thanks everybody for joining us today for the shock session. So yeah, I was asked with the daunting task of giving a summary of the year in review, which is really just not possible in cardiogenic shock. So I thought I would focus on some areas of knowledge that are really driving innovation in the field, especially relevant to the meeting here at CVI. So basically, what I first did was take a look at all the publications that have been put out for cardiogenic shock. So since 1947, the first publication, there have been over 19,000 publications to date, but over 855 publications just in the past 6 months. So I put this up to say it's really not possible to do the year in review in 10 minutes, just given the astronomical amount of information coming out in shock. Part of the reason we're seeing this huge spike in the number of data points coming out for cardiogenic shock is the fact that mortality remains absolutely unacceptable. We're at 1 to 3 mortality for all patients coming in with cardiogenic shock, 1 to 2 for AMI patients, which is our responsibility on the interventional side, and 1 to 4 for heart failure shock patients. So it's a massively important topic for the field of cardiovascular medicine, and we've all got to dig in to really expand the field. So I thought I would just focus on 3 major areas of growth that have occurred over the past year. One is expanding and adoption and improved definitions for SCAI stages, which has really started to help us clinically quite a bit. The second is a growth in machine learning or advanced data analytics to define the shock phenotype. And then third, there's a really interesting growth in the use of VA ECMO in cath labs, and we're beginning to really enhance our understanding of VA ECMO, especially for its use in cardiogenic shock as it comes out of the OR into the hands of interventionalists. So the first paper came out in January of 2022, so just made the cut for the past year in review. This is the SCAI Stages updated consensus document. But with the updated consensus document, we focused on the idea of trajectories of care, recognizing that it's not really just enough to define patient shock severity at the time of presentation, but you have to iteratively, constantly monitor the patient, and you can see them move through the different SCAI stages between deterioration as well as stabilization throughout the hospitalization. This, of course, then led to another paper. This came out from the Shock Working Group, basically looking at the SCAI stages, and this was actually motivated by Paul Tierstein, who asked me as we were showing the SCAI stages consensus statement. He said, I don't know how to use that. He said, there are a million different variables for each of the stages. He's like, someone just needs to tell me how to use this. And that was Paul's main comment. So based on that comment, we went and did an analysis, basically just picking up some very practical definitions of hypotension, hypoperfusion that you can get very quickly in the emergency room or at the bedside, and looking at treatment intensity, and then using that to define the SCAI stages. We made one minor modification where in SCAI B, we allowed patients who are normotensive but hypoperfusing to be into SCAI B, which was an important step, especially for patients with heart failure shock who may be normotensive but have elevated lactates. And what we learned from just that minor little tweak was that actually patients who present with SCAI B shock, I'll show you here, 90% of those patients at admission with SCAI B will deteriorate to either C, D, or E. And so what that tells us is that this is really the beginning stage, but it's also a very bad stage to be in. It also tells us this is an opportunity for intervention to get to these patients early as soon as you identify them as SCAI B, as opposed to waiting for classic shock, deteriorating shock, or extreme shock to finally manifest itself. Another advance that we did based on that, the advancing definition of SCAI stages, is to put out an app. So this app is now available, and you can use this to basically calculate the SCAI stages. It also has a hemodynamics calculator, so if you put in all of your hemodynamics, it'll spit out all the formulas that you don't want to sit there and calculate. And then it'll track your patient over time. So if you iteratively use the app, it'll start to tell you which direction your patient went in the more you put input into the data. And then this also will calculate your estimated mortality based on the data, and then also starts to push into our machine learning work with providing a different phenotype of shock, so going beyond the SCAI stages. And I think this is really important because as we start to emphasize the need for early identification of shock or early deterioration, identification of deterioration, the papers like this one, which I think was an important one from the past year, started to look at the kinetics of lactate. So sometimes you'll get a lactate and then you'll say, we'll check it again in 12 hours, we'll check it again the next day. Actually, it turns out that if you check it just in 90 minutes, That's sufficient to start to tell you, is this patient going in the right direction or not? So this is really the new CKMB or troponin of cardiogenic shock. You've got to cycle your lactates, and that term really has to become part of our interventional language, is did you cycle the lactates and were they going up or down? And that should tell us, are we in the right direction or not? This paper is a critically important one to read. Now, what we've been doing is collecting a lot of data. So the number of shock patients in our registry has started to grow quite a bit. We're now approaching about 11,000 within the next year. And this means that when we multiply that by the number of variables in the CRF, we're up to about 11 to 16 million data points. And what this allows us to do is now do some very advanced data analytics. I won't get into all the statistical part because I barely understand half of what the kids are doing these days. But I can tell you that what they've started to do is some really, really interesting analyses that implement some machine learning techniques, primarily to derive different phenoprofiles of shock. So we define phenoprofile 1, 2, and 3, cardiocentric, cardiorenal, and then multifactorial, multi-organ involvement. And it turns out that this phenoprofile was actually validated in multiple different registries, and now we know that this correlates with 30-day survival. So what this allows us to do is now if you combine SCAI stages with cardiac phenoprofiling, you can start to now get a better picture of the patient. What is the hemometabolic condition of the patient? And then where are they in that deterioration stabilization pathway? And so we think that this starts to move us a little bit into the next phase of better profiling our patients so that we can understand who needs intervention and when. And this was then validated by another paper. This is from Jacob Genser, who did it in the Mayo Clinic series, and he did exactly that. He took the same machine learning approach, used it in the MayoSet database, found the exact same 3 phenotypes that we just talked about, and then basically correlated them with SCAI stage and showed that there's a really nice correlation that if you have escalating SCAI stage as well as you get into the worst metabolic phenotypes, this correlates with mortality. So as this starts to come together, those apps that you're starting to see come out are going to start to incorporate all of this so you can start to predict what's the mortality at different time points throughout the patient's hospitalization. Now, one of the biggest areas that's seen a lot of growth over the past year is our understanding of VA ECMO. Now, VA ECMO, as you know, is starting to penetrate into the cath labs. We're seeing it in community hospitals. It provides an immense amount of circulatory support by draining from the venous system and pressurizing the arterial tree. One of the things that as interventional operators we're going to learn about with peripheral VA ECMO is something that I'm starting to call the pressure oxygenation paradox. What this means is that when you're delivering blood from the femoral artery, you have to actually pressurize the entire arterial tree and actually get the flow all the way up to the level of the aortic valve in order to perfuse the brain. If the patient has any sort of lung injury, this can lead to differential hypoxemia. And for this reason, what you start to see is that as your native ventricle improves, it's ejecting deoxygenated blood, and you have to mitigate this by increasing ECMO flow in order to push more of that oxygenated blood up into the aortic arch. And so what this means is that we now are starting to do different techniques where we have to put in a third cannula, for example, if we see differential hypoxemia. And this pressurization of the entire arterial tree from below starts to impose substantial amounts of ventricular load on the left ventricle. And that's one of the major limitations of VA ECMO. So you can see here that in this study where they tried to do low flow, VA ECMO 2.5 liters per minute versus 4.5, cerebral PaO2 was significantly reduced if you're doing low flow ECMO. So the caveat of peripheral ECMO is you have to use high flow. And the problem with that is you're going to cause more pressurization of the arterial tree, which is what drives the ventricular load. The other problem with this is that the other way we deliver more oxygen to the brain is we drive up hyperoxemia. And what happens is your PaO2 coming out of the oxygenator is around 400 or 500. And so what we've learned now over multiple papers, but this is the most recent one from Jacob Genser as well, is that if you have severe hyperoxemia 24 hours after initiating VA ECMO, this is associated with higher mortality. So the paradox of VA ECMO is you need pressure and you need hyperoxemia, and that can lead to problems in terms of how VA ECMO may not help and may actually start to work against itself. So the clinical conundrum is this high-flow peripheral VA ECMO increases stress on the heart by activating all the different components of arterial afterload, which is impedance, compliance, wave reflection, and vascular resistance. So what we're learning now is that people are starting to try to mitigate that by just basically using more pumps. And so this paper came out from ELSO, about 13,000 patients, another important paper showing that if you combine ECMO with some sort of unloading strategy, balloon pump or Impella, you get lower mortality despite having higher bleeding or risk of hemolysis. And this has also been now published in the J-ROADS. This is from the Japanese registry, showing that if you combine VA ECMO with some strategy of mitigating that load effect, that you'll get better survival. And this is from 2022. And more recently, from Benedict Schraga and Dirk Westerman, they also show that the timing of implementation of unloading is critical. So if you actually implement unloading with ECMO at the same time that you're activating both, that you'll get better results than if you have a longer period separating the two. So what we want to do is get a better understanding of how to unload with ECMO. We just published this paper, which is coming out in JACC Basic Translational. It gets into a lot of molecular biology, but what we learned is that if you combine ECMO with Impella, you can actually get some cardioprotection, but it doesn't actually lead all the way down to mitochondrial protection, which is an important component of reducing myocardial injury. And one of the things that's going to be very innovative coming out over the next month is what we learned is that VA ECMO actually depletes a critically important lipoprotein in your mitochondria called cardiolipin. So this is now getting into some molecular biology, so I'll apologize for that. But it turns out that this cardiolipin, if you don't have cardiolipin, as in the case of young kids who are born without cardiolipin, they develop a dilated cardiomyopathy with disrupted mitochondria. And so what this means is that we're starting to learn that VA ECMO in its hyperoxemia, high-flow environment may actually be leading to a myocardial effect that leads to a cardiomyopathy, and that's maybe why we're seeing impaired hearts coming off of VA ECMO. And what you can start to see, and this is an analysis we did of human LVs coming out of the OR who were transitioned on VA ECMO to VAD or transplant versus who are transitioned off balloon pump or Impella. And this protein is what regulates cardiolipin, and it's completely depleted in VA ECMO human LV hearts. And this is also seen in healthy swine. If you expose them to VA ECMO, this protein is completely gone. And that leads to a disruption of the mitochondria, and this is potentially leading to a cardiomyopathy. So you're going to see an immense amount of science come out over the next 6 months. Some of the most important trials are listed here in the cardiogenic shock arena. Will any of these change clinical practice? We'll wait to find out. Danger Shock just completed enrollment. That's a critically important trial. You'll hear about that probably in early 2024. And the ECLS shock trial also will be published and will be coming out in August. This is one to watch. This was for ECMO initiation in patients coming in with AMI shock. Just like IABP shock 2, TLA and colleagues now put ECMO into the circuit, and they're looking for a 35% treatment effect. And so you can imagine what the results of this trial might be based on everything we just discussed. So it's an exciting time in cardiogenic shock. I tried to do the year in review, but I think at the end of the day, we're just seeing a lot of knowledge coming out, and that's what's driving innovation in the field. So thanks very much for your attention.
So, Navin, that was really outstanding. And actually, for those of you who really want to be up to date with cardiogenic shock, go home and listen to that again, as that was outstanding. And I personally want to congratulate you with the cardiogenic shock working group and the data and the input that you've had to the field. It's been fantastic.
Yeah, thanks, Tim. Appreciate it.
Yeah. So I'm going to introduce, first of all, on my side, we have two panelists from Detroit, Dr. Dixon and Dr. Basir. And then on my side, we have two from Ohio. So this is Dean Boudoulas from Ohio State. So why don't we start over there? Simon, do you have comments about that?
Navin, that was a spectacular review. I echo Tim's comments and encourage everyone to go back and review that again, because I'm certainly going to do that. That was the best up-to-date presentation I've seen for a long, long time. I'm really curious on the sort of the north-south syndrome with ECMO, and I think that's a big learning area for us as interventionists in the lab. Is there any experience or any investigation with supersaturated oxygen therapy in conjunction with ECMO to mitigate that issue?
Yeah, it's a great question. So it's really important to distinguish supersaturated oxygen from hyperoxemia with ECMO. Supersaturated oxygen is hyperbaric oxygen, whereas the hyperoxemia with ECMO is not hyperbaric. It's basically just delivered through the ECMO circuit through flow, just like cardiopulmonary bypass. So two very different mechanisms. One thing to keep in mind with that data on north-south and also the high flow is that right now we as operators are being asked to use cannulas that are designed for surgeons. They're basically put in through surgical cut-downs. The cannulas are not designed for interventionalists. They're not friendly to interventionalists. And in fact, what happens is we are now basically creating peripheral ECMO, whereas these really should be most optimally done with central ECMO. So if all ECMO could be done centrally, that actually doesn't create the north-south syndrome. It doesn't create a high-pressure environment. You can run oxygenation at a lower level. The problem is that technologically, we're limited right now by doing peripheral ECMO with a short cannula sitting in the femoral artery, which pressurizes the whole tree. So I guess my point is that we've got a lot of work to do in this space, especially if we as operators are going to be doing more ECMO in the cath lab.
No, I would reiterate, I think one of the major points that you made, Navin, that I think is extremely helpful is how to practically take SkyShock stages and use them based on different metrics, right? And SkyShock stages was unique. It was created for the emergency room, EMS providers, medical intensive care units. But for those of us who are researching and studying cardiogenic shock, and we want to pool patients into buckets so that we can be comparable to each other, I think the SkyShock classifications, along with the iterations from the shock working group, are going to make a tremendous impact in being able to compare apples to apples.
Yeah, all credit for that goes to Paul Tierstein shaking his head, and Jeff Moses also shaking his head saying, no idea how to use this. So we wanted to make sure we solved it so that those guys could use it in their daily practice.
Yeah, Navin, excellent overview. Thank you for that. What I find intriguing is the mitochondrial level. So, as you mentioned, with a high flow state of ECMO, your total peripheral resistance is going to go up, which, because the high flow state and when you have fixed total peripheral resistance and an LV that can't contract, your LVDP is going to go up, your LA pressures in the way to offset that. And that's why we do the LV venting, which most of us probably practice that. But what I find extremely intriguing is that you didn't see it at the level of any kind of mitochondrial changes. So I know it's early and maybe not have these answers, but what do you think can change, or what can we do to mitigate that?
Yeah, we're really excited about the science coming out. For a long time, people have been tracking circulating mitochondrial DNA levels from peripheral blood in patients on VA ECMO and finding very high levels of mitochondrial DNA, suggesting that mitochondria have ruptured and they're releasing DNA into the circulation. This now starts to get down to the cardiac level, especially in the infarct setting, to give us more insight. And actually, this link to Barth syndrome was really quite exciting. This led to one of our R01s a couple of years ago, because Barth syndrome, actually, there are a number of drugs coming out for Barth syndrome. So we're about to release the data, and we'll be presenting it at the BCVS meeting for AHA next month. But we actually started to treat these preclinical models with drugs that are designed to stabilize cardiolipin. And if you do that with VA ECMO, you can actually reduce infarct size. And so this actually has huge implications for the field, because if that pans out to be true in a clinical trial, what we're now suggesting is that you can use VA ECMO and you won't see the negative effects on myocardial recovery, potentially by using a drug-based approach, as opposed to using more devices. So we're really excited to take a deeper dive into the molecular biology, because that's an area that's still been very, very poorly explored. But this link to cardiolipin and the fact that there are already human trials for Barth syndrome and other syndromes with cardiolipin deficiency allows us to potentially accelerate the ability to now translate that into a clinical trial.
All right, well, I'll introduce our next speaker, and then afterwards, Navin will let you introduce your panelists and let you take care of it. So our next speaker, this will be a great talk as well, and it's Cardiogenic Shock, What is the Best Protocol by Mir Basir, who maybe has created one of the best cardiogenic shock treatment centers in the United States.
Thank you, guys. Thanks for having me at CVI. It's really exciting. I love the meeting. I'm happy I don't have to stand behind a podium. I'm going to hover over Megha so she gets nervous because she thinks I'm going to ask her a question, but I'm not. So what is the best shock protocol? I don't know the answer to that, all right? I'm going to be biased and say the shock initiative is pretty darn good in AMI cardiogenic shock, but I think we have a lot of unmet answers. So these are my disclosures. So how many of you have shock protocols and teams in your hospitals? Hand raising? That's okay? Oh, not even half. Okay, so we have definitely some work to do. Maybe when I get invited to places, they have a shock protocol and team, but they're really kind of early in their phase. And what I think is important to emphasize here is that Just having a team is not good enough, right? Luckily, I'm a Packers fan and not a Detroit Lions fan. But the Lions, every year, they get excited because they have this new toy or they have this new player or something, and they end up still stinking, right? And you may have a shock protocol, you may have a shock team, you may have a new hire, but you really have to make sure that you evaluate your outcomes and look to see if you're actually changing strategy in these patients. So what is the benefit of a shock protocol or a shock team? Well, the first key element of this is that you have to actually decrease the delay that is taking place in these shock patients every day. And what it really is a multifactorial delay. There's a delay in recognition, there's a delay in early treatment, and then there's actually a delay once they've started to get treatment. There's a delay in, we're going to slowly increase our vasopressors and inotropes before we start to think about utilizing hemodynamic support devices. We're going to wait for RV failure to be manifested with suction alarms and patients tripling their vasopressors and inotropes before we start thinking about RV hemodynamic support devices. But all of these delays are really probably one of the most key elements of why a shock protocol and team can help improve outcomes. The second thing that's really important here is that a shock protocol and team should be able to differentiate the different kinds of cardiogenic shock. It's not all one bucket. And Navin has showed this time and time again. And the working group has also shown that there's multiple shock phenotypes. The two big buckets here are the decompensated heart failure shock patients. And what's really important about those patients is that they have compensatory physiology. And so they may come in and they may have elevated lactate and some high filling pressures, but maybe with some inotropes, maybe even with the use of a balloon pump, you can get them out of shock. And if you can't get them out of shock, well, then they need usually to completely take over their heart and really work them up for LVAD and transplant. And then we have this whole bucket of the acute patients that come in, and particularly the AMI patients, right? And what's really important about these patients is that they actually have very high mortality early on. They really are a flip of a coin, 50-50 whether they'll make it or not. And they do not have compensatory physiology. And because they don't, when they go into cardiogenic shock, their end organs see a lot less cardiac output after their AMI, and you need to support them earlier to try to get them out of shock, start them on some medical therapy so that you can start that process of compensatory physiology and then ongoing care. The third important principle with a shock protocol or a team is to actually use objective measures to be able to make your decisions. A long time ago, right, we would just think to ourselves, hey, listen, this patient's going to do okay. Nothing else that needs to be done. This is my gut feeling, right? Well, gut feelings are gone now, right? You really have to provide objective measures, whether it's through lactate, Swan-Ganz catheters, hemodynamics, to really be able to make decisions. And it is those objective measures that should go into what decisions the shock team and the protocol make. And the other important aspect of a shock protocol and team is to use all forms of hemodynamic support devices. They all have roles in potentially helping treat your patients. We have the example of a balloon pump. So a balloon pump was studied in the CRISP AMI study. So maybe that's shock A and B, right? And it's clearly hypothesis generating, but if you combine the endpoint of death, shock, new or worsening heart failure, there was a statistically significant change with the use of an intra-aortic balloon pump, but not each of the individual variables. Again, something that warrants more study. Clearly, a balloon pump should probably not be used in higher stages of cardiogenic shock. And we know that balloon pumps could potentially play a role in patients with heart failure. And that's something that hasn't been studied very well and probably deserves a lot of attention. So again, one of the tools within the toolbox. Clearly a lot of bias here, but I think that the Cardiogenic Shock Initiative has really changed the landscape of STEMI cardiogenic shock, right? I think we've provided a uniform mechanism of treating patients with Impella, hemodynamic support monitoring, guidelines for weaning and escalation, and we have to be realistic here. Cath labs, 99% of them have the availability of Impella. Less than 5% of them have the availability of putting in ECMO. So other than myself, Navin, who can put in ECMO by themselves without talking to the surgeons or critical care or anybody else? So a handful of people, right? So this is really a problem. If we're going to actually take care of these patients, we have to have all of the tools to be able to take care of them. And VA ECMO is part of those potential tools. But I think from a practical and realistic standpoint, everyone has Impella to use. And so now you have a system to be able to use the device that you have available, mitigate complications, do it in the right way, use it early so that you can keep your patients from those, again, higher stages of cardiogenic shock. And just like Navin said, there is going to be an explosion on the use of ECMO coming, right? We've had 2 trials that have been done, all small trials. The first is the ECLS shock study, but this is not Holger Thiel's study. This is the precursor study. And the 1-year outcomes for this study, or the 30-day outcomes, are interesting, right? Mortality was 19% in those who were treated with ECMO, and the standard of care arm had essentially doubled mortality of 38%. Small sample size, so you can't make much out of it in and of itself, but compelling double-digit difference in mortality. You can look at the EuroShock trial, which was also a small trial. The 30-day mortality was 43.8%, and the standard of care mortality was 61%. Again, another double-digit difference in mortality. And so I think, actually, that Holger is probably going to show, the first trial that actually changes outcomes in cardiogenic shock with support device. But I don't know if he's going to present only the 30-day data next month, because it may not make a difference at 30 days, but maybe by 1 year that will be different. And we also have this overlying population of cardiac arrest. And this is a really unique population. It takes a lot of care for these patients. I'm not sold on this yet, but there is data from our friends in the University of Minnesota who essentially have shown that the use of ECMO in active resuscitation is, associated with improved outcomes as well. And this was done in a randomized pilot study out of a single center. We'll see if that can translate anywhere else. The bottom line, however, is we're all trying to get to the scientific truth together as we're taking care of patients in real life, right? And so we can't wait for a randomized trial, but what's positive about all of this is that observation after observation after observation has shown that we're getting better, we're improving outcomes using protocols and shock teams. So I think this is the new era until we get more data. As Navin showed just a minute ago, we're getting more data minute by minute, day by day, and so we're going to fine-tune this, but I think this treatment pathways are here to stay. So to conclude from my end, the best shock protocol is the one that helps clinicians identify and rapidly treat shock. The most effective device for that given patient is really based on local expertise and then the hemodynamic detriment that that patient is feeling. There's a lot of nuances in picking out which hemodynamic support device to use, and ECLS shock, Danger, and Recover 4 are going to fine-tune that, but we're going to be using these devices going forward. And I think particularly in the STEMI and AMI shock realm, I think NCSI's data is pretty compelling, and I think this really should be the standard of care in all institutions until we get more data from randomized controlled trials. So thank you so much.
Great, Barbara, that was terrific. Can you tell us a little bit more about the latest data from NCSI? What's happening after NCSI?
Yeah.
So where's that going to evolve to next?
No, it's a great question. So we're doing a second version of NCSI, as you know, called the Ceramics trial. So, NCSI was a coalition of the willing. So 80 hospitals, mostly community-based. Some people had only Impella CP and they didn't have any other forms of escalation. And really, we know, being in a shock center that has all of the tools and the toys, that our outcomes and decisions are slightly different. And so what we're doing is we're actually fine-tuning the number of sites and looking at 20 sites that have full ability to escalate and looking at what are the outcomes of patients when you come in with STEMI shock, but you come into a center that has all of the escalation tools and capabilities. So it's going to be 120 patients. We've recruited 10%, 12 patients so far, and we're excited that we'll probably end recruitment sometime later this year.
That's great. Congrats. So I'll introduce our panel. So we have Allison Hall, who's one of the directors of the program with us. We also have Timothy Mixon, and we also have Amirali Masoumi joining us on the panel. So Allison, any comments or questions for Babar?
Yeah, so I'd just like to make the comment that, you know, a lot of this data that's being presented in terms of a focus on better definitions and better ways to actually follow patient progress, that's really relevant to me. You know, when I look at my practice, I don't necessarily have all of the MCS tools at my disposal, but what I kind of realized as I was trying to get that going, I actually refocused, and I focused more on the early management of these patients because there was so much upstream issue in terms of actually identifying these patients and, you know, defining their shock subtype and doing excellent early management, both in the emergency department itself and in the CCU early on. So I think the more that we kind of have these standardized definitions for early care providers, this is going to hopefully help improve that a big portion of this patient subsets care early on. And I also thought it was interesting the role for AI and some of these apps that are going to help early care providers actually more readily do the calculations, you know, without having to overthink it and, you know, just hopefully facilitate earlier care for these patients. So, yeah.
Yeah, I am incredibly encouraged by seeing all the clinical trials that are going on. You know, for many, many years, I've told my fellows that the devices that we love and use are simply the devices that we haven't tested yet, because for so many years, every time we would test them, balloon pumps and beyond, we wouldn't see promising results. So I think that's going to be, it is a very exciting time to be practicing medicine where we're going to have so much evidence-based medicine. And just, you know, commend you and your group for how you have extended out these protocols, and that really is the foundation of most of our hospitals and how we operate. And just that mindset of doing things in parallel rather than doing things sequentially, of, you know, having interventions and at the same time thinking what's the next intervention that we're going to need, tracking that with objective data. I think that's going to make a tremendous difference in outcomes.
Yeah, you know, you mentioned community hospitals, I think, to me, it's very interesting the time that we spend in these hospitals as well, and you know, early mobilization as important as early identification. You identify them and try to move them up to the centers that they have, you know, capabilities for advanced therapies, because as you know, time is an essence, and you start losing the end organs, and then the doors starts closing on a lot of these patients. We talk about ECMO. Navin mentioned that the ECMO is coming into the cath lab, and I 100% agree that this is an OR concept that now we inherited those and then trying to implement in our patients. The concept of, for example, the type of flow, that's a partial flow or full flow, that's another important thing. And the other thing that I try to highlight always is the aortic valve or pulsatility for these patients. And these are the things that we need to consider before, because it's just not a machine to dial it up when we have more flow, and you will benefit of that. As you see that now we have more of a cardiac and cardiomyopathies with only just flow, not to mention oxygenation and et cetera.
Yeah, that's great. Before Tim introduces the first case, Babar, just one last comment from you. So there was a call for a randomized controlled trial for shock teams. Do we need to randomize centers with shock teams versus without shock teams, or is it something that should be obvious?
I think it's something that should be obvious. We have stroke teams. There's a little bit of data, but not a great amount of data. We have, you know, structural heart teams, advanced coronary teams. You know, teamwork is the dream work in 2023. I don't think we need to focus in on that. I think we need to spend time focusing in on therapeutic interventions that are going to change outcomes with simple things like a Swan-Ganz catheter that you're doing, with support devices, with all of these other tools and pieces that we put into these shock protocols and what the teams use to make decisions. So that's just my one opinion.
Great, thanks so much. Tim, do you want to introduce the first case?
Can I, first of all, two of the best, I've been in a lot of cardiogenic shock sessions in the last 2 years. two of the best talks to start that out that I've heard. So can we ask one question before we go on? Because now we're going to have 4 really great cases. How many in here are either part of the Cardiogenic Shock Working Group or the National Cardiogenic Shock Initiative? How many sites are at least part of one of those 2 things? Fair number, but I do believe, I'm going to come back, I think actually having a shock team and a shock protocol is the start. And keeping track of your data, and both of the 2 of you have done a great job of actually providing us more data. So now we're going to do 4 cases, and our first one is Pervez Mirage.
No, actually, Stephane Renfret, so there's been a change to Stephane Renfret because he lost his flight last night to Mirage, so Stephane Renfret will do the first talk.
You're close, Stephane.
So, for those who are disappointed, I'm Stephane Renfret. So, I will present, and not Dr. Mirage. I'll be presenting this STEMI in a 50-year-old mother, and you'll see why things can be confusing sometimes. So, these are my disclosures. So, this patient was I was told she was 50 years old. And 4 weeks postpartum. So it came into my mind. I said, like, wow, it's impressive. She's in the ER with an anterior STEMI, and she has VF arrest upon arrival of ambulance. And then she has chest pain and it started with chest pain while holding her baby. Cath lab was busy, so I was doing a case, and the guy prior to that was 46-year-old, with the distal left main and a trifurcation. So I had the end full for some time. And then the ER doc says, like, I've got this 50-year-old patient downstairs, STEMI, postpartum. I'm like, 45 minutes, so we decide to give TNK. And then within 15 minutes, she has VF, hypotension, and I have to speed up. Like, I've never done left main stenting that fast. I gotta tell you, it was like speed of light, and then got the other guy out the table, and on the way up, finally she gets to the cath lab, and first of all, she's 40. She's not 50. Makes more sense. And then I all realized as soon as she got to cath lab, she's hypotensive, she's crashing, and I know it's a SCAD. So you can all see here horrible coronaries. And with a better injection here, you can see how terrifying it is. And you can see, you see the catheter coming back. And actually, it's me losing consciousness while I'm still holding the catheter. And the catheter comes out at the same time. So at this point, we have no other choice than to start PCI. But I know it's gonna turn quickly, so I'm already calling for ECMO because I know it's gonna be, and I don't think an Impella might be the way to go. And there you go, wired all branches, and I drop a stent in the LED, and all of a sudden she crashes. So we go on CPR, ECMO is inserted, and unfortunately it took about 45 minutes because it was in the middle of the night. Which was a bit long for our center. I do no further angiography. The patient, she's blue, cold, she's looking awful. And we get her out to the CCU. The initial ejection fraction was 10%. She has big abdominal distension, and she has free fluid in the abdomen. And this is the first case. I had a case this year that was the same in another institution, but she has a massive hemoperitoneum, and finally she had a laceration, a hepatic laceration from the CPR. So that's one advantage for those who don't have the Lucas. Is clearly something that I think can avoid that complication. And then finally she improved the next day. You have 10 to 40%, and then she's doing good, and we're bringing her back to the cath lab for decannulation because we were doing all percutaneous decannulation like you guys do. And I started with the angiogram. I think this angiogram is just beautiful. I just wanted to show you how coronary heals if you give them the time to heal. So this LED was stented, it improved, but everything is dissected. We've got TIMI3 flow. You can see the stent in the center of the LED, and you can still see some dissection flaps behind, but you can, and finally we didn't do anything further. She did remarkably well. Actually, this is her right. So unfortunately, 3 days later, she had an intracranial bleed. We decannulated her. Afterwards, she had a DVT. She had an IVC filter. She was transferred to the CCU, not from the ICU to CCU. And then that intracranial hematoma weaned, and basically a month later, she was discharged home for rehab, and she's alive. So basically, 3 years later, she had epilepsy, likely from the prior stroke. She's still suffering from hemianopsia, but that's the only thing. Her LV is normal. She had an aortic dissection, a distal aortic dissection as well. So probably she was FMD. And with the ECMO cannula, she has this dissection that we manage medically. So in conclusion, I want to tell you that, never assume a woman can have a baby at 50 years old. This is something when you're busy, you should probably ask yourself another time when the ER doc comes to you in the cath lab and says, I have this 50, I should have said, 50? No, I didn't say that. So on top of it, don't think it is from coronary artery disease, because that's, as proven otherwise with females younger than 50, it's SCAD. Obviously, giving lytics is controversial in the setting of a STEMI and SCAD. I hear Jackie Saw always saying that it is one option, but in the era of primary angioplasty and coronary angiogram, I think avoiding, you know that this made her really sick, and that extended the dissection. And be ready for the worst in these cases. And obviously, if you've practiced putting cannulas and everything outside a world of lytics, you'll be much better. She didn't bleed. She did good on an access site perspective, but you can imagine that this becomes a bit more, you're a bit more worried to put all these cannula and equipment in post-lytic patients. So that's basically the case I wanted to show you, and I think it's an example of having an ECMO in your center can definitely save lives, and she's one example. Any question?
There's also a microphone back here for the audience. Anyone wants to ask a question, just feel free, just raise your hand, I'll come to you.
At some point in my quick algorithm is that, when you become quickly hypotensive and the pulse pressure is becoming very narrow, you know that you will be quickly in a situation of circulatory support, not LV support. And these cases usually don't do well with an Impella. Of course, that's the thing you can do more quickly, but in my experience, it's invariably that you have to put the ECMO in. We were concerned about all the accesses, and we wanted to go for one access, one arterial access, not two, and minimize the risk of bleeding and everything. So we waited for the ECMO. And by the way, cannulas were in, and we were up and running 45 minutes. It's a bit long, right? Usually you can be much faster than this. It's all because it was, a surgical sort of old, and the perfusionist was home, so you got to let all these people come in. On the daytime, it would have been like 10 minutes and up and running, but at night, it's another issue. But yes, in retrospect, we could have probably bridged with an Impella and then maybe replaced for the ECMO.
Yeah, Stephane. Oh.
There was none. No, there's no calcification. These coronaries were like non-coronary disease at all.
Yeah, so firstly, she's extremely lucky that you were on that call that night, right? Because SCAD is extremely challenging to take care of, and whether you're in the true lumen or not in the true lumen, that's something you're very familiar with. But I think for the rest of the group as a whole, really important to mention, because if you stent in the false lumen, that patient's going to get transplant, LVAD, or pass away.
Yeah.
So really, really important point. This other thing that I thought, I would have probably put a CP in her right away, because the thing is that you know you're in trouble. You know bad things are coming. And we have the instinct of saying that, yeah, you know, the stenting is going to help, but it's not going to help right away, right? Yeah. And so I think that 45-minute CPR time, the liver laceration, all of those things, could it have been avoided? We don't know, right? I mean, at the end of the day, she made it. She's very lucky to have gone through something so severe and gotten through it. But maybe some of those things would have been a little bit easier to tolerate.
Yeah, and you're right. I mean, we were slowly shifting into this mindset of unload first and PCI after. Here it was like maybe after the angiogram it should have been pause, support, and then think of something. But the angiograms was so dismal, and you're sort of thinking that it's something will be. Something really bad would happen, and it's a tough call at this point to think that you're going to spend all that time, because yes, an Impella can be quite fast, but it's still longer than wiring and dropping a stent, and that was, you know, the educated guess that we made at that time. It's just like, let's try to drop a stent somewhere and made her get some TIMI-3 flow. So all what you saw was within like about a minute. But despite this, she went like really south. So yeah.
Is that a question from the audience?
Yeah, it's a fascinating case, Stephane. From my time at Emory as a fellow, you know, we put together a case series of these cases at Emory. And there was this lady that we had. Initially, we did conservative management. Her SCAD was in like OM. And she was like doing okay, balloon pump. After 2-3 days, we were about to discharge her. On a day that we thought we were going to discharge her, she got recurrent chest pain, and then we had to take her back, and her actual dissection went all the way to left main. And the decision was to do more of an emergency bypass. So really, these are the patients that I would keep them in the hospital for a good 5 to 7 days. Even if they're doing okay for 1, 2, 3 days, this can come back really early on, even though you're doing conservative management, which is, you know, by guideline is the right thing to do. These are not to go home in 2-3 days.
Yeah, you're absolutely right. Most of the patient, initially, when you've done the angiogram, if you are able to do a conservative management, they'll do better. I think PCI should be considered only when you have TIMI, you know, like a massive left main like this. You got to do something. You just cannot leave it like this. But again, I think the way we do PCI for SCAD needs to be improved and tested with other therapies, such as cutting balloon, STAR technique, fenestrating the hematoma, other things. But you know, most of the time, we'll go for the safest approach, which is to drop a stent and hope for the best. But when you have more time than in a terrible case like this, I've done so far maybe 6 cases where if I can wire the true lumen, I will try to fenestrate the hematoma, and with either a cutting balloon or just a regular balloon. If I cannot wire the true lumen and the vessels occluded, I'm very comfortable with dissection reentry techniques, and then I will start the vessel, and I will restore TIMI-3 flow. And it's one of these techniques that when you learn into complex PCI that you can bring into those cases can be very helpful in an acute dissection, iatrogenic dissection, but also spontaneous dissection. So when you understand the mechanism, stenting is not always the solution.
Stephane, thanks for a great case, really complex. Thank you so much. So we're going to invite up our next case presenter, Megha Prasad. So while Megha gets set up, we'll just ask the audience in the era now of contemporary MCS practice. So how many here would use an Impella for that case up front versus via ECMO? Okay, and how many would do the Impella pre-PCI? Okay, great. All right, terrific. Megha, welcome, and we're looking forward to your case.
This is a 74-year-old gentleman with a history of bilateral knee replacements who came in 6 days prior. He was basically presented with postoperative chest pain when he was in the hospital. So he basically was at this outside hospital. He had a bilateral knee replacement, came in with postoperative chest pain with the normal EKG, no labs or additional testing performed, was discharged. So he had 2 discharges before the presentation that I'm going to show you. His history was he had had a cardiac clearance with the normal EKG and echo 1 month prior to surgery. His past medical history is significant for type 2 diabetes, hypertension, hyperlipidemia, carotid disease with 50% stenosis and no plan for any management, but he was on Plavix for that, and premature CAD in his father. His social history was significant for a 20-pack-year history of smoking, and then he had been on aspirin, Plavix, metoprolol, and lisinopril, but the Plavix had been held for his bilateral knee replacement. He presented 2 days post-discharge, the second discharge, with continued chest pain, nausea, not responsive to the PPI and Maalox that he had been prescribed at discharge. His blood pressure was 78/52 with the heart rate of 78 and this EKG. So I was covering for a friend at the time at a satellite hospital, and so we went ahead and activated the cath lab. This is a story of no good deed goes unpunished. On arrival to the cath lab, he was in complete heart block, so very different from the EKG that I had received. His heart rate was in the 20s with a blood pressure of 58/63. I started with placing a TVP and putting up a swan as we got set up. So typically our practice at Columbia is we are very aggressive, especially in shock patients, with getting a swan up as quickly as possible. Often people say that that takes time, but we're able to get it up pretty quickly, and so we started with that as we got set up for our diagnostic angiogram. You can see the numbers here, an RA pressure of 24, PA systolic of 46, PA diastolic of 27, and his wedge was 25, PSAT was 18% with a PAPI of 0.79. So this is his angiogram. So he presented with what we assumed on his EKG, sort of a proximal RCA STEMI that explains the numbers that we were seeing on his right heart cath, and he had some residual LAD disease as well that we weren't planning on dealing with in the initial setting. At this point, his blood pressure was 53/23, but continuing to decline, and the numbers are as I showed you. So I'm going to start by turning it over to the panel and just sort of hearing how you would approach this, because I'd love to see if there's other alternatives before I tell you how I did it.
Yeah, sure.
So I would say, I guess I would push back against the right heart cath early, in the sense that I think we all know what's going on. He's in cardiogenic shock. And we'll learn more, and you can certainly learn some different things through the right heart cath, but I think that's probably not what we would do. I think in this case, we might go directly to a support device, even before angiography, possibly. And the other idea out there, which I think has been largely forgotten, is that you can oftentimes, in fact, with most workhorse wires, you can actually pace the heart through the workhorse wire. And so we would typically go straight in with the JR4 guide, wire the lesion, begin to pace. That way, it saves you more time having to get a transvenous pacer. And then if you feel like you need support before you do thrombectomy or balloon or whatever you're going to do.
Tim, what support device? You said you'd put him on support?
What's that?
What support device in this case?
I think in most cases of AMI shock, we would start with a left-sided impella. And of course, you did have the data on, a low PAPI, and we may get into trouble with that. But ultimately, that's at least connected to left-sided heart shock.
Yeah. Other thoughts? Next steps?
So I have a lot of comments here. So I think that in general here, we're talking about RV shock, yes. Probably very responsive to pacing and fluid bolus. It seems that the patient probably already got fluid boluses because the RA pressure was already 18.
3 liters in the emergency department on the way up.
So you're refractory to that. I haven't heard anything about vasopressors and inotropes. This is not LV shock. I thought the distal left main looked okay, at least it was a cranie shot, but assuming that that's all normal, I think you go ahead and either do, myself, I would probably do penumbra, IVUS, try to direct stent, and I would not put in support up front.
Any other comments?
Yes, can I? I was asking here from the audience. I was asking, what about the temporary pacemaker? Did you put something or not?
Sorry, could you
temporary
repeat that?
They put a temp wire in.
TVP, yeah.
Yeah, so I think it's a great case. These are really challenging. So I kind of agree about the hemodynamics up front. You happen to be there, so you got your drive-by PA catheter, which is phenomenal. In terms of support, it's really challenging to know. Sometimes with these patients, it's really helpful to get a quick echo. The wedge pressure of 25 tells me it's not purely isolated RV failure, so I'm a little bit concerned that there might be BIV involvement here. And these large wraparound RCAs, you see it filling, there's a small circumflex there. That RPL is massive. You've got ST elevations in the lateral leads as well as in the inferior leads. I'd be concerned that the septum's gone, the lateral wall is gone, and you probably got some BIV component there. I think it's not unreasonable to put in a left-sided support device, but the concern is that if the RV is the problem, then you're going to be escalating support, or you're not going to be getting adequate support. Having said all of that, if it is truly, so I would first get an echo while you're getting into the lab. If the LV is down or impaired, it's reasonable to put in a CP device, run it at a low flow state just to get things going. Most of these RCAs, they're going to do fine once you get the vessel open. So the idea of pre-PCI RP for RVMI is probably not necessary. In fact, vast majority will do fine with vasopressors, so dopamine to get started, add levofed if needed, get the vessel open, and then start to make decisions with the hemodynamic guidance. The most important maneuver hopefully you're going to do is after you put the patient on support or you've stabilized them, is to monitor them for about 30 minutes in the cath lab to make sure that they don't deteriorate or deteriorate after they leave the lab, and then you can escalate in the lab. But why don't you get on with the case, because otherwise we're going to take up all your time.
No, that sounds great. So the bedside echo showed a EF of 10 to 15%, not great views. It was on the sauna site, but it looked like everything was down. He started to slow his heart rate down despite being on the TVP, and then started to have a few runs of PVCs where we thought he was, maybe impending VF was the other concern there. He had already been started on high-dose inotropes, and that's sort of how we started to get some ectopy on the thing. So let me continue. So first, like I said, I was covering for a friend for a few hours at a satellite hospital, a hospital that I was not as comfortable at as I am at the main center, because I spent 99.9% of my time at the main center. And so I didn't have all of the support devices that I normally would. But doing quick math, and this slide from Dr. Kapur, I know my PAPI is less than 1, and so I'm thinking I have some sort of BIV issue here, especially given the echo. And so at that point, I started working. I started asking for an Impella to be opened. I called for ECMO because of the PSAT of 17% and the fact that I didn't have it immediately available. I wanted to get that process started. I was told that there was 3 to 4 hours of wait time because the team was dealing with a sick patient at the main center. As we were going up with the guide on one side, I put up the Impella, given that the blood pressure at this point was now sinking down to the 40s, 30s. I called for an RP Impella because of the situation that was going on with ECMO, as I thought that if I needed to ship this patient down to the main center, I was going to need some sort of BIV support potentially, and I only had one console because the other console was not working, so we started working sort of simultaneously on that. And then, as I got the Impella and I had improved blood pressures to 60s to 70s systolic with the PSAT of 24, as I started getting started with the intervention. We've talked a lot about thrombectomy at this course, so I'm not going to go into the details of the interventions, but it was complicated in that, I took a microcatheter down, I crossed it with the Pilot 200, a lot of thrombus. I initially did not IVUS. I took a microcatheter distally to make sure that I got all these branches. I used a dual lumen to get into all the branches to sort of improve flow as best as I could, because each one of these branches was quite large, and used that dual lumen microcatheter to inject to see where the thrombus was. Finally, at this point, the patient continued to be hypotensive. I did use some vasodilators distally, but was limited obviously by the blood pressure and max dose pressures and already on an Impella. I started with manual aspiration thrombectomy and balloon angioplasty while we set up the penumbra, and then used the penumbra, which, to be honest, didn't help much, and I didn't get much clot back from that. So we did use the penumbra. The other thing I've started doing, I didn't store the fluoro given how quickly that was going in that case, but this is from a separate case. I've started using these long peripheral balloons in these cases, and those have been very helpful. We sort of started doing it during COVID when we were having these cases of heavy thrombus burden, but it sort of helps macerate the clot in a way that it gets it on the wall and at least gets me some flow. So that actually was the most helpful in this case as well. And then, ended with IC nitro IVUS guided PCI and had a blood pressure of 62/47, but still with a pretty low PA-SAT. At that point, I called back to the main center to try and discuss what the options were at this point. Given the ectopy I was having and given that his blood pressure was still unstable, I didn't feel comfortable putting him in an ambulance for a 1.5-hour ride to the main center. So by that point, the RP Impella came. Now we have the RP Flex, but this was, I think, 3 weeks before the RP Flex, before we had that. And so basically we went ahead and put in the RP Impella. There were some challenges associated with this, so this took me a lot longer than I would have liked. It took a solid 15 minutes to get the RP Impella up, but his PA-SAT improved to 48%. He was awake and responsive through this whole time, and we ended up transferring him to the main center. One question just for the panel. I think people would probably agree on this, but my tech looked at me and said, I think we should just fix the LAD too while we're here. And I said, no, I'm not going to, but I'd like to hear if anybody would have done that prox LAD while they were there.
Comments from everybody? I would say no. Say, we've got the target. Let's focus on stabilizing the patient's hemodynamics. Maybe just for time, do you want to continue and then we can open up the discussion? Yep.
So we placed the RP Impella, transferred to Columbia with that PA-SAT of 48%. He actually, the ECMO team was waiting for him ready to cannulate over there, but he improved well enough that they didn't end up cannulating for another 16 hours or so when his lactate started to trend up and his hemodynamics suggested that he would need ECMO. He did require ECMO. His course has been complicated, but with improving hemodynamics, I don't have a case resolution yet on him because he's sort of had a very complicated course I'm not going to go into, but he is alive. The two things I want to talk about here are, this case led to discussions to increase access to ECMO at our satellite hospitals. Since then, there have been a couple similar cases that have been able to be cannulated to ECMO efficiently at those centers. And the RP Flex, I think if I had had at the time, when I heard that it was released, I was really regretting not having it at the time. My take-home points are right heart caths, I do think help with decision-making in shock. In this case, it was sort of more obvious that the patient wasn't doing well, but it did help guide the fact that I had a PA-SAT and I wanted to put in that RP Impella before I shipped the patient off. So it helped me decide what my threshold was to transfer. You do your best in these challenging situations with limited resources. It's important to understand the role of biventricular or right ventricular support and understand that an Impella can hurt a patient with isolated RV shock, and that I'm sure the panel will go over. I found long balloons very helpful in these cases, so sort of having access to a couple of those is great, and to identify systems issues and sort of try to be a part of the solution when you find yourself in these situations. Thank you.
Phenomenal case, and my first question is, what did your friend that you were pinch hitting for give you in return for covering for 2 hours?
This is, Amir knows, this is a hospital that gets 20 STEMIs a year, and so I think I was just unlucky. So.
Okay, all right, so you let that one go. We'll open it up for comments from everybody, but just to comment briefly, this was expertly handled. It's exactly the right thing to do, everything you did. I think getting that echo or getting some assessment is really, really critically important. It identifies the BIV problem. There are a lot of nuances on the hemodynamics, which I won't get into right now, but I think the most important thing is to get the patient on some support. It's okay to use a CP in these cases. The main thing is to just make sure you don't jack up the flow up to P8 or P9. You can run it at a lower level. You can also add a vasopressor and an inotrope just to stabilize and bridge you to make sure you can get through the PCI and add MCS, escalate MCS as needed at the end of the PCI. I think if you were at your center, you probably would have gone on to CP and then added ECMO, which would have been the right condition would have put in ECPella in this condition. And we're starting to see more of these BIV cases, especially if they're critically ill with cardiac arrest, massively elevated lactates. Our algorithm at Tufts is if the lactate's above 5, we go to ECPella as opposed to BiPella. But I certainly think that in this case, if you don't have the availability of ECMO, going on BIV support on BiPella support makes a lot of sense. The RP Flex will afford you the opportunity to go through IJ, which is really important actually from a technical perspective, because once you put the RP in the femoral vein, exchanging that out for a venous cannula to then convert to ECMO can be really tough. And so actually with the RP Flex from the IJ, you can actually have full access to your IVC to then go ahead and escalate, if needed, to an ECMO configuration. But I'll open it up to comments from the panel or to the audience if anyone has comments for Megha.
Yeah, so Megha, that was a great case, great job. This is me here. The only comment I had related to was systems of care stuff. So instead of trying to set up these ECMO programs at these satellite hospitals, the other option that could be pursued is this Mobi ECMO thing, where actually they can come from Colombia itself to the satellites and help you or operators there, and in that way save a lot of time. And I think that's kind of what's been at least practiced to some extent in Phoenix.
Yeah, that's sort of how we have it. I think we've increased the capacity of that team so that if there is a second issue, that they're able to sort of come up. So, but no, at individual centers, we still don't have anybody.
The issue with mobile ECMO is some of the states have regulations, and we ran into this about New York. So I know there are some initiatives at the moment in New York State, but there are some regulations. And the other thing, I mean, this was done perfectly, but I started adding to my mental checklist, especially when we have delays and we are in the cath lab. I hope we are very good with access, so I will try to get as many accesses as possible, because we know that these patients start, sliding down the shock path. They will lose the distal perfusion because of the constriction. So while I'm waiting, I'm trying to put like 4 Frenches as much as possible in these cases to foresee that the disaster is going to come more and more.
That's a really good point, actually, because as was mentioned earlier, many centers also require, the surgical team to be present. They don't have independence to cannulate in the lab. So at the very least, if you do have to involve your surgical team, you can get started by getting those access points in place, and it makes things a bit quicker when the team does arrive. But again, it points to the fact that ideally we'd all be more independently able to just go ahead and get our access done in the lab without waiting.
All right, that was an outstanding case, and we could talk about this for another 10 minutes, but we need to stay on time. So our next case is on Dr. Dean Boudoulas is going to do case number 3.
Great, thank you. Dean Boudoulas from Ohio State University in Columbus, Ohio. I'm going to go over a case here. Let's see, right button. Okay, no disclosure is relevant to this case presentation. So this is a 57-year-old gentleman, history of coronary bypass and multiple PCIs, ischemic cardiomyopathy with CRT and ICD placement, was at home and had recurrent episodes of shocks from his ICD, defibrillated successfully, so he came to the emergency department. There was found to be an VT storm, interrogating his device, recurrent VT in the ED, electrophysiology was on board and started amiodarone and lidocaine infusion. Due to recurrent VT, the patient was intubated with deep sedation, but throughout this whole process remained hemodynamically stable. Transthoracic echocardiogram demonstrated a LV that was severely dilated with severe LV systolic dysfunction. Right ventricle was mildly enlarged with mild systolic dysfunction, and there was no hemodynamic significant valvular disease. There's an image of that. Peristernal long axis, you can see dilated LV not really squeezing well. Patient underwent a coronary angiogram, was found to have severe in-stent restenosis, and per digging through the medical records, it sounds like this was a recurrent theme. Has been reported previous of the distal left main and the ostial proximal circumflex, CTO of the prox LAD, and then non-obstructive disease in the right, and had occluded bypass grafts. It's just a quick image of that. CTO, LAD, you can see the in-stent of the left main, prox, ostial circ, and just by the appearance, looks like potentially more than one layer. Here's another view. The right coronary, non-obstructive. Patient underwent PCI, and at this stage, the decision was just to do a quick balloon angioplasty, increase the flow. But to be honest with you, with this heart, with probably scar throughout the left ventricle, the VT could be coming from anywhere, but was to optimize at least what could be optimized. Here's a view post-PCI. So the patient went back to the ICU, continued to have ventricular tachycardia, pulse present, still hemodynamically stable. Electrophysiology tried anti-tachycardia pacing, cardioversion, multiple attempts, but this just resulted in just temporary cessation of the VT. So underwent a VT ablation, ganglion block, again, not successful, recurrent episodes of VT. Now the patient started to develop hypotension, started to have acute renal failure, elevated lactate, elevated liver enzymes, and this was despite optimal medical management. Right heart catheterization was performed. You can see the RA pressure was elevated 18, PA 42 or 37, low pulse pressure with a mean of 39, a wedge of 35, index of 1.4, cardiac power output of 0.45, PAPI of 0.55. So based on our algorithm, and I want to thank Dr. Kapur because we came out several years back to visit his site, and this is really based on his algorithm, and we just made some changes. And so just to pause here, who would put a device in? And if you did, let me ask you, would be, if you follow this algorithm, it'd be low index, 2.2. You'd go to biventricular failure, elevate RA, LV ADP is elevated, your PAPI is low, so technically this is saying biventricular failure. Would you do Bipella or would you do ECMO? So who would do Bipella? Who would do ECMO? Okay. Excellent. Well, even if you follow this algorithm, persistent VT, we'd say ECMO. Now, this is probably a good discussion, and it's probably not going to get resolved in the 5 minutes we have, but ECMO in our institution is placed by cardiac surgery. We do it in the cath lab because surgery has to be present, and mostly that is driven because these patients go to a cardiac intensive care unit where they're managed. And that's kind of where the rate-limiting step is. We do have an ECPR program which has increased our utilization of ECMO in the cath lab, which has helped with the collaboration, but still, because we had issues with getting surgery timely and the ease of placing Bipella, the decision at that time was to place the patient on, place an Impella CP and an Impella RP. Well, the patient went back to the ICU, and the key here is continuous monitoring, reassessment, which was done. Index remained low, renal failure worsened, lactate acidosis, elevated enzymes, VT storm persisted. So at that point, the shock team was brought together, and the decision was to place the patient on a ECMO. This was about 16 hours after the Bipella. So the Impella RP was removed, the Impella CP was placed in place to vent the LV, even though the mitochondria probably is still suffering, and to stabilize the patient. Well, now the patient went into refractory VT, unsuccessful defibrillation attempts, thus was placed on the transplant list and was quickly actually got heart transplanted. This was 2 weeks after hospital admission. The rest of the hospital course was a little bit bumpy, but actually did quite well. 6 weeks after hospital admission, the patient was discharged to home in stable condition. So in conclusion, prognosis of shock, as we know, is poor. Close monitoring and reassessment is essential in cardiogenic shock, including use of invasive hemodynamics. Timely escalation of therapies needs to be considered if the status is not improving. And appropriate use of current technologies and consideration of advanced heart failure therapies, including cardiac transplantation, may improve outcomes. Thank you.
Dean, that's a great case. You know, as we wait for people to ask questions, please feel free to comment on Dean's case. Tim, it sounds like a theme is coming up with all the cases, that there's a system problem in terms of interventionalists not being allowed to or being able to cannulate for ECMO without the need for a surgeon to stand by. So, Dean, what does your surgeon do when you guys have them standing by and you guys are putting cannulas in? And what's the rationale behind that approach at Ohio State?
Yeah, I mean, it's not, I mean, I'll tell you, traditionally it was always surgery. Then when we developed an ECPR program, these patients came from the field in cardiac arrest right to the cath lab, and it was interventionalists essentially getting the access. I mean, we all know, we're biased. We feel like we're, you know, pretty proficient in this compared to surgeons. But it's not the decision that the surgeons can come in and we can even put the ECMO in the cath lab. The issue is they go under their service, under their care in a cardiac intensive care unit, which is different for us, the cardiovascular intensive care unit. Two different floors, two different areas. And so they own the patient, they take care of them, and they work with the intensivist to take care of those patients. And to be honest with you, if they're taking care of these patients, You know, they probably should have the right to be involved from the beginning in making those decisions. But that's where I see the system needs to change, is the care post and who's taking care of these patients. And that's probably, you know, for our institution, doesn't mean it's the same for your institution, but that's something that I think drives who's putting ECMO and who's making the decisions, is really the post-care.
Yeah, I mean, I agree. It's not so much that the interventionists need to be given the keys to the kingdom as much as you need to get the whole shock team together at the very beginning. That's probably the best solution, actually.
Yeah. And what's interesting is we have a shock team, we have a page, it goes out, but because of the acuity of it, typically, you know, it's going to be a heart failure specialist, an interventional cardiologist, intensivist, and a surgeon. And from those four, who do you think doesn't make the call most of the time because they're tied up in the OR as the surgeon? And so even from the beginning, the decision sometimes is being driven by the intensivist who co-manages these patients on their floor. So it's complex. It's not as easy as we're just going to put ECMO in and be done with it. It's something that I think needs to be looked at really close from beginning to end.
Yeah, I think it's
Since
a really
we're with
important
friends, I
initiative.
can just say
Oh, go ahead.
nothing wrong with interventional cardiologists having the keys to the kingdom. We put in 95% of our ECMO, including for our surgeons, peripheral VA ECMO. We manage 85% of all ECMO patients, and that is cardiology-driven with interventional cardiology, advanced heart failure, and one dedicated cardiac critical care person. So I think, you know, it is not out of the realm of possibility to build and get up to a program that can potentially accomplish that.
Well, I think I would take it one step further. I think it's probably going to become the standard, you know, within the next 5 years or so, is that actually all ECMO, vast majority of ECMO will be implanted by interventionalists. And also you know, at Tufts, what we've started to do is really empower the intensivists to have more of the point position in terms of decision making. So especially in those urgent cases, like you said, surgeon's not available, the intensivist is the one who's going to join you in the cath lab, make a quick call, you're going to cannulate at that point, and then we'll figure out the bed situation later. But what we've done now is we've expanded so that all units are capable of ECMO. And that's critically important for the non-surgical units to be able to handle ECMO. This came out of the pandemic with BV ECMO going into the MICUs, but then also starting to need more people who can sit ECMO. So the nurses are now trained on ECMO, so you don't need to have a perfusionist bedside. These are really important systems of care that we've got to start building. And I think we've got to start empowering, and I think this is a great opportunity for Sky to take the lead and try to start building out more of these ECMO systems so that we don't have delays in care. And not that I think this case was really well handled, trying to get a bipella in to temporize really complicated by V-shock, but refractory VT on that algorithm is a very clear indication for total cardiac pulmonary circulatory support, which is really best with ECMO.
Absolutely, and as written in the protocol or algorithm, so it's frustrating. And one thing we've actually started shifting towards, and I think it's a good point, is intensivists being more involved. Because there's even interventionalists. We're tied in cases sometimes, and we can't take that call. So we are moving that way, so it's nice to hear you say that.
Navin, can I just piggyback on what you said? It's me here. So I think the challenge is that intensivists are a heterogeneous group, even in AMCs. Some of them are coming from cardiac anesthesia, some of them are coming from emergency room pathways, and some of them are coming from pulmonary and critical care pathways. And I think the key, in my opinion, long-term, the solution, I think, is they all seem to have a great fund of knowledge in taking care of ICU-type situations related to bleeding and related to other surgical type or airway or hypoxia-related issues, but somehow there's a disconnect in their understanding of hemodynamics and cardiac protection and myocardial oxygen consumption, the kind of language that we in cardiology, as we speak and learn from you in the space. I think the role really should be, and we are far from there, is have a whole new specialty where you have a group of cardiac intensivists who come through the pathway of a cardiology fellowship. And I think, obviously, we're nowhere close, but I think that's the next big need if you really want to talk about med education and graduate medical education, with a pathway that's, I think, an advanced fellowship in cardiac intensive care. And I think that would be the answer long term.
Yeah, I agree with that for the long term. I think that makes a lot of sense. That's emerging, a lot of interest in hybrid programs. Just very briefly, I do think that, you know, when we started our intensivist program, we had pulmonary anesthesia, all non-cardiac people, and I was very concerned. But actually, one of the most important things is that we identified 2 physician leaders within the intensivist group who were fully educated, brought up to speed, and actually didn't need to be brought up to speed, fully got it. They were cardiac anesthesia. And they started to disseminate and run the intensivist pool. There are now 30 intensivists in the rotation. They cover in-house 24/7. They run, and most specifically, they implement an algorithm. So they're all following an algorithm. They're not independently deciding what should we do here, what should we do here. And I think that's where you've got to get physician leader in the cath lab, physician leader in the OR, and the intensivist group to get together, and heart failure, agree on the algorithm, educate everyone on the algorithm, and implement the algorithm. So until we have the subspecialty care of cardiac critical care well established with enough people and manpower, I think that's going to be down the line. Dean, thanks so much for this case. I think we've got to get on. I can feel Tim staring at me. So Tim.
Yeah, we need to stay on time. We're going to do our 4th case. One quick call.
Okay, just a quick question to all of you. Where I've practiced, I've always had access to ECMO, traditional ECMO and everything. Now that there's this Tandem Life that advocate for easy ECMO in remote places and labs that don't have the support, anybody has experience, has used it, can actually testify if it works well or not?
Yeah, I think probably, there are a lot of folks, and Barbara, please comment, but these devices that are coming out, CardioHelp, the LivaNova platform for Tandem Life, they're designed for rapid access ECMO, not for necessarily long-term ECMO for a period of weeks or months. That's really when you switch to CentroMag. But for immediate use in the cath lab, they're great for just getting hemodynamic stability. Barbara, you want to comment on that real quick?
Totally.
Okay.
All right, our last case is Amirali Masoumi.
Okay, so I think this is, doesn't have anything with revascularization, so hopefully I don't disappoint anyone. It's a 71-year-old female with really no known past cardiac history, a very functional lady. She runs a very successful business. The only thing with her that I put it up here is she had a history of rheumatoid arthritis, not necessarily on any immunomodulators, no chronic prednisone, and hopefully it will become more evident why I put it up there. Came to one of the sister hospitals with kind of vague symptoms. They did an EKG concerning. She had some troponin leak, not very bad, but she ended up going to the cath lab. These are the images that, sorry. Can I go back? There was concern for the LAD territory, a little bit hard to see that. And this is the RCA. And these are exactly the sequence of events, how they obtained the cardiac images. They started working to revascularize the LAD. Patient was hemodynamically stable. She had a very good mental status. She was on room air, and not necessarily any excruciating pain, etc. So after about 40 minutes or so, they decided to stop. As you can see, there is I don't know, probably a little dissection or bleeding out there, but nothing, no harm, which was great. Then decision was made to do an LV-gram, and this is the LV-gram that you can see here. Now we know the problem. At this point, the shock team was activated. We have a dedicated shock team, which includes a call to our surgeons, interventional cardiologists, and heart failure. I've been cursed to train in both, so I get both calls from heart failure and also the interventional aspect of that. But that's how the decisions are coming down. At that point, even though she was stable, she had a blood pressure, But she started having some atrial arrhythmias, and that was a trigger for our shock team to ask to implant a Impella CP before transferring her. And she got airlifted to Morristown with no right heart catheterization. We review a lot of these shock criteria, and I want to put a big box, and before we start going down the pathways and get excited about the devices, is what is the exit strategy for these patients? I'm sure Navin, Babir, you hear this. Okay, we have this patient. And say, what's the exit? What's the exit for this patient before we commit, especially more resource-intensive devices? We started gathering more collateral information. Of course, she was, we were lucky that she was stable. Immediately, we took her to the cath lab. We did a shunt run, and this is the information that we had. QPQS was about almost 2.6 to 3. Despite the fact that she had a very low PA-SAT, a very low cardiac index, she was still stable. But we started now requiring a little bit of a pressor. End organs remained stable. She started having some right lower extremity ischemia. And the lactates, as Navin mentioned, started creeping up a little bit. This was the echocardiogram that you can see the rupture. So inotrope added. Immediately we gathered at the bedside, discussed the options with the patient, and again, we had the luxury to discuss more of a advanced therapies with patient and family. Decision was made to immediately go to Impella 5.5. She improved her cardiac output, her indices. She remained intact from the end organ, including the brain. And at the same time, we expedited the evaluation for advanced therapies, especially now with the new allocation systems. A person like that with a favorable blood type, we considered transplantation, even though the patient herself had some hesitation about transplant. Regardless, as we were going through this, it was a hospital day 7 that she started requiring a little bit more of the pressors and started having atrial arrhythmias more frequent. And at that point, decision was to move with the VSD repair and cabbage. It was very successful. Impella came out post-op day 4, and she was discharged on the post-op day 14. This is the echocardiogram a week after in clinic. She walked into our clinic. As you can see, sorry, this thing is not working now. Can we move forward with the slides? I'm kind of stuck.
You're good. You're good. Try again.
I'm trying my best.
Okay, time for discussion.
No. Can we? It doesn't go in.
1 second, actually. They're working on it, so give us 1 second.
So regardless, these were, the images. Can we proceed this? Oh, they're working on it. I think Babir, you, Rashad, and Dan Burkhoff had a very nice paper with the simulation of Harvey, real data with the simulation, and they correlated to see that the role of MCS in VSD, the ischemic mechanical complications of MI. And go to next. That's the paper that I found it extremely helpful to understand, to see that different modalities, different configurations. Of course, they all come with a price, and we need to be aware of that before implementation of those. the role of right heart catheterization, understanding the shunt size is extremely important. In that paper, you will see that how the paradigm and dynamic changes based on the shunt flow. And these are the take-home messages, taking care of at least a handful of these patients. Early identification, and early identification, yes, starts from the field in gathering information. Often, we are going to the cath lab and we may not have a very clear understanding of how long the symptoms been going on, the presentation, physical exam, but have a systematic approach to our diagnostic catheterization, the role of LV gram and how we do the LV gram before we commit to all these, advanced techniques to try to open up the vessels, and a multidisciplinary approach, which is important. Ideal MCS support is important. More and more we have more data that the Impella devices could change the fact of unloading LV and help the shunt flow. ECMO and Impella definitely it's a possibility. We had cases that we managed like that and to extreme shock. And that a paradigm shift in surgical approach. I'm not a CT surgeon, and I hope we have, I don't know if we have CT surgeons here, but more and more data is coming. They call it sandwich from the RV approach, have been published. The timing of surgery, like classic teaching, is that we have to wait at least two weeks. To me, it's a little bit of a Darwinian. If they survive 2 weeks, probably they can survive. So these timings and these techniques are evolving, and I hope, with more data, we'll be able to provide better care for the patients with rare but very significant mechanical complications of them.
Well, it's 10 o'clock, but that's another absolutely outstanding case. And I think what I would say of this is the 4 cases are really fantastic in that they illustrate the importance of having multidisciplinary teams, and that shock is a heterogeneous disease. Shock, acute MI shock is different than heart failure shock, and it's different than patients who have mechanical problems. So really outstanding. So Navin, final comments?
Just to say, I think this space is evolving. Congratulations to all the case presenters, and thanks to everybody for participating. It's pretty clear that as interventionalists, we're going to be seeing more and more shock come into the cath lab. We've got a lot of variability in terms of our clinical practice. We've got to make that more uniform. Access to technologies is also quite variable. And also what we do after the cath lab is also quite variable. So there's a lot of work to do, but this is the deadliest condition in cardiovascular medicine. And I think it's really important for all interventional operators to make sure you're fully educated and up to speed, helping us push it forward and participate in randomized trials. There'll be more to come on that. Thanks so much.